focus on the basic examination aspects of the chest. I realize in my teaching with you guys, this is going to be my last session that I'm teaching is cardiology. I'm moving to bits. But this is going to be an introduction to semester 5 session to try and cover some of the critical, difficult aspects about murmurs and sounds that we get in cardiology. Okay. So we're going to focus on the heart sounds, S1, S2. We'll touch quickly on S3 and S4. We're going to talk about the cardiac cycle. We're going to talk about systole, diastole. We're going to talk about murmurs, just in basic the principles of murmurs. Okay. So what I think we should do is, I'm going to write down here a few basic concepts, and then we'll take it from here, from there. Okay. You guys have done your cardiac physiology? Yes? Yes. Great. Let's take it in the order of play. Who can tell me here, how does the first heart sound get formed? Fantastic. Karen, what a start. Closure of the AV valves. So the tricuspid valve on the right-hand side of the heart and the mitral valve on the left-hand side, when they close, in which part of the cardiac cycle? There's only two. Pick one. Do they close in diastole or in systole? Who thinks diastole? Kelvin? How would a valve like that close when the heart's relaxing? True. So that can't be diastole. It needs to be systole. So when the ventricles contract, the pressure builds in the ventricles and shuts the tricuspid and mitral valve. That turbulence from the closure of those valves causes the first heart sound. So that's the first principle we need to get home. The sounds you're hearing in your ears is not the physical touching of the actual valve leaflets. It's the turbulence of blood generated by the closing of the valves. Now, let's talk about the first heart valve, first heart sound. It's made out of a closure when these two valves close simultaneously. They actually close not exactly at the same times, but very close. You can't really distinguish it with your normal ears. Alright? Now, what will influence the loudness of the first sound? We just discussed, or I've just mentioned, how does the sound get formed by the turbulence of the blood with the closing of the valve. What would make that valve go close louder? When you listen to the valve, it goes doo, doo, as opposed to. Now, what do you think?
The volume of the blood.
Oh, now tell me, talk to me now. You're on the right there, you're on it now. What about the volume of the blood? In your brain? In your ears?
In
Where?
the chamber itself.
The volume of blood in the ventricle. Perfect. I'm very excited now. Tell me how it will influence the sound.
I think if there's more blood, then sound would be louder.
Okay, that's the one option. More blood in the ventricle, louder sound is the one option. Jaco, you're shaking your head like this. What do you think?
The other way around.
Why do you think it's the other way around? You're right.
Because there's more space for it to blood.
It's more tumble the right effect.
Yeah.
Okay. You're right, but it's not the right explanation. The more the leaflets move during closure, the more turbulence it generates underneath it when they close. Now, what happens if the blood goes into the ventricle? Like, let's say I'm in the atrium, here's the valve, mitral valve. The blood is rushing through into the ventricle underneath. And as the blood gets filled in diastole, the leaflets float on top of the blood. And when the systole happens and the ventricle starts contracting, those leaflets have a little short distance to travel and they close. So the fuller the ventricle, the less turbulence it creates when it closes, the softer the first sound. Now, does it make sense to everyone? This is a rule in the SCARPA session. You can give me a T, but just like this, discreetly. Then I know you're not with me, we rewind the tape. Otherwise, this locomotive keeps going. Okay, are we happy with that? Ground rules established. Philip, are you with me? Okay. Now, can you think of any condition, Phil, that would cause less blood to be in the ventricle?
Hypovolemic shock.
Hypovolemic shock? Yes. Good. Anything else? A heart issue.
Stenosis within the AV valve.
Which valve? Let's say we're on the left. We're on the left
Yeah,
now.
bicuspid valve.
Okay, what do we call the bicuspid valve for normal people?
Mitral.
Mitral valve, yes. Okay. I forgot that the bicuspid valve is also the mitral valve, yes, but no one uses the word bicuspid valve. It's only tricuspid and mitral. Okay. Perfect. So if you have a stenotic valve, so that leads us to what is the definition of stenosis? It's a valve that doesn't open properly, so it's narrowed. Yes. Okay, so please people, there's only two types of valve lesions that can happen with a particular valve. It's either, okay, let's say it's normal, works functionally normal, or it doesn't open properly, then it's stenosed, because it causes a narrowing and there's turbulence through there, or it doesn't close properly, and then it's incompetent. So it's either, the synonym for incompetence is regurgitation. So a mitral regurgitation and a mitral incompetence is the same thing. Okay, that's an important thing to realize. Okay, so we've got a reason for getting a loud S first sound and a soft first sound. We spoke about the less filling in the ventricle, hypovolemic shock, we did that. But also if you have a stenotic, for instance, a stenosis of the mitral valve, that leaves less blood in there, so it closes more forcefully because there's less blood. Another cause that you have that is when there's variability in the diastolic length of the heart cycle. Now, which condition does that cause that? Anybody there from the posterior peanut gallery? What heart arrhythmia that you know about, and I'm sure you've heard this before, about this condition, gives you variability in the length of diastole?
Atrial fibrillation.
Thank you from the posterior peanut gallery over there. That's the anterior peanut gallery. Oh, absolutely. How does that work? Fred, can you help us?
Well, basically, you said atrial fibrillation. So basically,
Great answer.
There's a problem in the atria where it's basically due to misfiring, essentially.
Yeah.
And then what happens is the timing between when the ventricles full and when the atria contract is not the same.
Yeah, essentially in atrial fibrillation, you have multiple ectopic pacemakers firing all at once. So the atrial speed is actually around 600 a minute. Can you imagine the effect of the ventricle if it had to conduct at 600 a minute? It's barely coping at 150. Okay, so it would not be compatible with life. But luckily the Lord has built in the AV node, which filters the 600. Okay, and it lets it through irregularly. So then you have a beat, pause, so it creates variability in the length of diastole because of the variability of the filter. The drugs we give to treat that condition affects the filter to make it, if the amount it lets through is too quick and the heart rate's 120, the patient's not feeling well because the filter is too weak, we give drugs to strengthen the filter to bring the speed down to 80 or 70. Alright. So if you have a long diastolic fill time with one of the AF filtering issues, you're going to have a what of S1? A loud or soft? Yeah, okay, but let's say you're taking a cycle where there's quite a long diastolic. Look, it's long, short, short, long. It goes like that, the diastolic length.
So it's soft, maybe more blood.
Yes, so if there's a long diastole, it's going to be a soft first sound. If there's a short diastole, it's going to be loud. So one of the clinical signs of an atrial fibrillation is variable intensity of S1, depending on the variability of the length of diastole. Got it? Isn't that cool? Okay. You'll learn all about atrial fibrillation. I made a video about clinical examination and cardiac exam where I talk a bit about AF on that aspect. One of the 3 clinical signs of atrial fibrillation. Okay, so for S1, caused by the closing of the AV valves, and the intensity of S1 is affected by the ventricular filling volume. which is affected by diastole, which is also affected by the valve leading to the blood going in, as opposed to also the systemic volume of the patient. Is everyone happy with that? Okay. That's basically S1, sound 1. For now, there's a bit more stuff that you can read in Talik O'Connor, which is your Bible for clinical examination and clinical science, but for now that will do. Let's move on to S2. Who can tell me from that group over there again, who's not had my, I've not had an answer there that I'm liking, what causes S2? Fantastic. Mayat?
Yes.
Is that right?
Okay.
Can you give me, is that your surname?
Yeah, we have the
You want me to
same
call you your surname? Nusha. Nusha, tell me quickly, can you give me the two valves that forms the those valves?
You have the aortic orifice, the valve around there.
Aortic valve.
Yeah, and you have the pulmonary.
Okay, so the aortic and pulmonary valve.
Yeah.
And in which phase do they close of the cardiac cycle?
Should be in,
Think now.
diastole.
Correct.
Yeah.
Why?
Because you'd have your ventricles relaxing, so the blood that you pump into the arteries would flow back down by gravity.
They would love to come back, but they can't.
Yeah, so they
We
shut
close
down
the valves.
Yeah.
Good. So that's why, so this one closes, S1 closes in systole, this one closes in diastole. So between the two, there's got to be movement of blood. Yes. So where's the pulse of the patient that you feel? Is it in systole or diastole? This is not hard.
Diastole.
Must. You're pulsing in diastole. You must have a unique system, unknown to medical science. The pulse that you feel in your neck or anywhere in your body has to be linked to the pump. So when the systolic pressure is generated, you get an injection of blood into the aorta, you feel a pulse. So the pulse is here. Everyone happy with that? So between the first and the second sound, lip, dip, is the pulse. So any sound that you hear that is on the pulse must be a systolic sound, since the pulse is in systole. That shouldn't be very hard. Okay. We know that this sound is formed in diastole after the systolic phase. Okay, and we have the aortic and pulmonary valve. Now, let's go to these two ladies up front here. How many, does the second sound have a splitting component? No. Who thinks no? Who thinks yes? Okay. Muhammad? Other Muhammad? Tell me, what do you think about a splitting second heart sound? What do you know about that?
Basically, there's both sounds, but you don't normally discern between them. But if the one...
Is it abnormal when you hear splitting?
No.
What does a split mean? So it goes here, as opposed to lip, as opposed to lip.
It's just a slight difference in the time between the two sounds.
Is it normal? Do we all have it?
Yes.
Or are you a bit abnormal if you have it? Is it a problem? Normal? Who votes normal? I'd love to have a splitting second sound. Who says yes? Who's keen not having it? LB? What do you think? You have it actually. We all have it. Okay, it's nothing abnormal, it's a physiological thing. But how do you know if it's physiological, the splitting of the second sound? Because as Fred said, it's when the aortic valve and the pulmonary valve close on different times. Now, what on earth would make your second valve split normally?
Got different size changes.
Hopefully not. But no. Yes.
Any resistance or high blood pressure. So it's more systemic high blood pressure or pulmonary high blood pressure.
What will happen when there's systemic hypertension?
In the aorta, there will be more resistance on the blood coming out, so it might push the blood back.
Causing the valve to close
Sooner than the pulmonary.
prematurely
Yeah.
compared to the other one. Yeah, that's possible, but that's not exactly how it works with that one. It's normally a delay.
Yeah.
Normally a delay. What would cause a delay in closure? Not a premature one, but delay.
The pressure to perform to something because of inspiration.
Now you're getting there, Fred. Inspiration. Tell me about inspiration. It's not going to necessarily It is going to
Well,
play
there's
an influence in the
there's a
pressures.
There's a storage capacity on venous return,
On the left, back to the left atrium.
which causes a delay because of the one side. So the
Good.
the aortic valve is slightly
It's going to be slightly correct. So look what happens. Here's the full download. Are you ready? There's the T. Okay, here it comes. Don't worry. How many people had the T with that one? There we go. You see, you're helping your country friends. Good. Guys, can I just say, when you do a T, you're helping your colleagues. Believe me, you're just brave. Okay. Other people are going, please go T, please go T. Okay. Listen to me now. When you take a deep breath, you increase the venous return to your heart because you are increasing the negative pressure in your thorax. Happy? Okay. So you're going to have an increased preload going to the right hand side. Simultaneously, you're going to also, taking a deep breath, pull a bit of blood returning to the left atrium through the pulmonary veins. You're going to pull a bit of the vasculature of the lungs. So there's going to be slightly less blood arriving back to the left atrium, less blood to the left ventricle, less stroke volume. Your baroreceptors pick it up, and then they increase the heart rate because you drop your blood pressure, which you increase the heart rate. When you take a deep breath, your heart goes faster, and you take more blood in. So what happens is there's a little bit of a discrepancy in the volume of blood being pumped in that second, between the right side having a bit more and the left side having it less. So your aortic valve closes a bit early compared to where your pulmonary valve closes. So on inspiration, you have the split, and on expiration, it goes back together again. Alright, so that's the normal physiological splitting of the second sound. Do we all get that? Good. Now, the team over here, can you think of any condition that would give you a fixed split second sound, where there's constantly a bit more blood on the right hand side? I'm going to be impressed if you get this one. Kim Lake?
Atrial septal defect.
Oh, well done, you are redeemed. Very good. Now tell me, how does that work? If you're going to do this, then you're going to be a cardiologist for sure. How did you work that out? Just tell us how your brain works.
It's like a volume load, it's equalized.
You must explain it that I can understand it.
I'm not too sure either.
Guys, have you realized that medicine is becoming a bit more verbal now? You have to explain what do you think, and I'll tell you, it's not a quiet subject anymore. Me and my books, and I write my tests. It's vocal. You must speak it. Kim, come on, Mr. Kim.
Okay, so
How did you come up with the ASD? Just tell me, how did that work? Well, was it just a stab from the dog?
Basically, but if there's a defect in the septum, the volume equalizes through each chamber.
In the atria.
Yeah.
Okay?
And then basically there's always going to be a split.
Okay, can I help you? Maybe this is how you thought. Which side has got more pressure, higher pressures, left or right? Luke, in the Free State it's the left. Eastern Cape it's the right, maybe. Not the left. Okay, so the left-hand side of the heart has always got a bit more higher pressures, right? Now, when you have an ASD, an atrial septal defect, the foramen ovale hasn't closed properly. So there's a constant move of blood from the left atrium through when it contracts to the right atrium, which means there's going to be constantly more blood on the right hand side going across the tricuspid valve into the right ventricle. So every time the right ventricle pumps, it's going to have a little bit more blood compared to the left, because the left is emptying through the foramen ovale and the mitral valve into the left ventricle. Hence the fixed split second sound. It does also move with inspiration, but it doesn't close, that you hear lip dip, lip dip. You always hear lip dip, lip dip. It's fixed. So when you ask your patient and you listen to that second sound, take a deep breath, and you hear there's the split, and it closes and it doesn't go back. And the patient is complaining of tiredness and a big heart. You're thinking ASD. Okay, so the ASD eventually can lead to heart failure, because that right side of the heart is working harder than it should, pumping the bigger volume, and hence you develop heart failure. Okay, happy with that? Good. You guys are doing well, really well. Okay, so that's the second sound caused by diastole, again, closing of the valves and the turbulence it causes. Now you can imagine, similar to the S1, what's going to increase the loudness of S2? We don't really talk too much about a soft S2. It's possible, but it's more about a loud S2. Come on, Calvin, you were on the right track there earlier. Let's just use you now properly.
Hypertension.
But that's a very broad term. We have a left and a right now.
Okay, systemic and pulmonary hypertension.
Yeah, so systemic hypertension would give you a loud second sound on the aortic component of it because of that pressure that's pushing it back quite loudly and the turbulence it creates. However, pulmonary hypertension, remember the pulmonary side is a low pressure system. So if that pressure goes up, and I'll talk about in a few seconds about what causes that, and there's hypertension that develops in the pulmonary vasculature, and it forces that pulmonary valve closed from the lung side, and you get such turbulence that essentially you can get a palpable P2, which is the pulmonary aspect component of the S2. So you get an A2 and a P2 could combine as S2, aortic pulmonary. All right. So the best sign for pulmonary hypertension is a palpable P2. So you put your fingers on the pulmonary area where you would listen to the pulmonary sound, and you can actually feel a tap. That means the turbulence caused by the closure of that valve is so severe that you can feel it. Okay. Are we happy with that? Okay, so a palpable P2 is an important sign in medicine. It's a sign of pulmonary hypertension. How do you develop pulmonary hypertension? Well, there's two ways. There's a primary and a secondary. Primary means it's like essential hypertension. We don't know why, but you're developing high pressure in your lungs. Mostly it's a vascular disease. Secondary pulmonary hypertension is much more common, and that's because of certain lung conditions that give it, and cardiac conditions. If you constantly pump more blood into the vasculature of the lungs, what's going to happen to the pressure in there? Increase. If you push 5 liters of water into a 3-liter balloon, the balloon is going to take more pressure and try to compensate for it, try to thicken its walls to try and handle the pressure. So pumping more higher volume blood into the lungs will cause pulmonary hypertension eventually. Also, if you lose surface area of the area that you pump the blood into the pulmonary vasculature, like for instance in COPD, chronic obstructive pulmonary disease like emphysema or chronic bronchitis, because of the destruction of lung, you have a reflex, physiological reflex, called hypoxic vasoconstriction. Have you heard of that before? You're going to do it next year. Okay. What that means is you are trying to shunt the blood in your lung vasculature to the areas where there's actually oxygen. It's very cool. Okay, so oxygen up here, all the blood up here, please. Let's get oxygen blood. That's actually what the lungs are supposed to do. Now you can imagine if you lose a lot of blood, lung tissue because of lung disease, and all that vasoconstriction happens because there's hypoxia in your lungs. Now you have all the blood vessels, or loads of them, constricted, but the same volume of blood going in. What's going to happen to the pressure? Same volume, less area to pump it into. So it's either more volume, same area, or same volume, less area to pump it in, causing pulmonary hypertension. Okay, that would give you a loud S2. Is everyone with me still? Happy? So the sound we're hearing is turbulence from blood, turbulence caused by the closure of valves. Just quickly want to mention S3 and S4. These are pathological heart sounds. They are called additional heart sounds. You shouldn't normally have an S3 or an S4 unless there's specific circumstances going on in the heart. The S3 is a hard sound to hear on its own, like doof, there it is. But the sound it makes sounds like this. Listen. What does that sound like? A horse running. It's called a gallop. So a gallop rhythm is because of an S3. See, I'm making 3 spots with my fingers. So there's So if you have a fast heart rate, with a third sound, you get a gallop. And it's not so much that you hear the third sound, but you hear the general rhythm, that galloping horse, low range. Sorry. My wife. Anyway, so that's a gallop. Where do we get an S3? That's the big question. Our S3 is formed when there's a bagginess of the ventricle. It's a dilated ventricle, normally. It's quite floppy, and it's when the volume of blood hits that baggy ventricle. So which condition would give you a baggy, floppy ventricle? You, sir. JT.
What in this law? You have a baggy ventricle. Ventricular tachycardia.
Dilated cardiomyopathy? And what would dilated cardiomyopathy look like, patient clinically?
Older patient?
No. It's okay, but what I'm saying is, what is the condition called? If I give you a baggy ventricle, is your heart going to work properly?
Cardiac failure.
Cardiac failure. So somebody with heart failure, with a dilated ventricle, could have an S3. Why is the heart rate up? Yeah, so the stroke volume, because of this baggy ventricle, can't pump properly, so you just pump more. If you can't pump properly, you pump more times. So they have a bit of a tachycardia with a third sound, gives you the classic gallop. Alright, so just in summary, an S3 therefore is a ventricular sound that you can find in heart failure with a patient with a quick heart rate, tachycardia, and it sounds like a gallop. These are all in your notes. Okay. What is an S4? See, Karen's been in the textbook. That's great. That's why she's on it. Who haven't answered the question yet? Tatu. What do you think is an S4? Don't read it. You can say I have no idea.
I have no idea.
Okay. Let's find out who has an idea. Zandri, any ideas?
I can take a guess.
Yeah, that's fine. Have a stab at it.
Probably atrium?
It's also to do with the ventricle. It's also to do with the ventricle, but it's an atrial sound coming from the atria, but it's because of ventricular pathology. Let me give you a tip. If you have a heaving apex beat, then you might also have an S4. Does that help? What is a heaving apex being indicative of? Any idea? Lungi?
I don't know. What does heaving mean?
That's the question. So if you know what a heaving apex beat means, then you would get it. Karen, can you help them? Left ventricular hypertrophy. So if you have a thickened left ventricle, and the atria contracts against that thickened left ventricle, then you can that causes an S4. So both of these sounds, are they diastolic or systolic? Are they?
Diastolic.
I just said the atria contracting. Is that systolic? No, it's at the end of diastolic. So this is an end diastolic sound. Can sometimes sound like a split first sound because it's just before the first sound. Yes? Cardiac cycle. This one is mid-diastolic because of the volume of blood falling onto that ventricle. It's all in the tally and in the note. Okay. Right, are we happy with these heart sounds? Yes?
So, I just want to ask, if you had a torn quarter tendon or a papillary muscle wasn't working and the valves were not entering the atrium,
Meaning an incompetent valve.
yeah, so which sound would that affect? If it affects S1, how would it sound?
Well, that's a good question. How can S1 form if the valve is leaking? You can't develop an S1.
Okay.
So you have a in systole, you have a murmur. Because to form S1, you need a closing valve. So that's another sign of, for instance, a mitral incompetence, is that you don't hear the first heart sound very well, you just hear a murmur. That's also an interesting question because that's how you determine between is this systolic murmur the whole of systole or just the ejection phase of it. Because remember, systole starts and then the valves have to close, then you get ejection, and then systole stops and then it is the diastolic phase starts when the aortic valves close. So we have to sometimes make a distinguish, is it a pansystolic murmur, the whole of systole, or is this murmur ejection only? If you can't hear the first heart sound, it's normally pansystolic. So you would normally have do. So that's an ejection systolic. It's between, you can definitely hear the first sound and the second sound, and the murmur is in between the sounds. But sometimes you just hear, you can't hear the first sound, you just hear the sound, the murmur, and the second sound. That's pansystolic. Okay. So these things are getting a bit more complex now. Okay. Are we happy? Any other questions? Are you happy with S1? Yes, Jacob?
Is the S2, the split of the S2 sound and S3, is it clearly distinguishable?
It is normally, because this one sounds like a gallop if you have an S3. Tally talks about Kentucky, Kentucky, Kentucky. That is a sound, that's how it sounds. Versus the S4 sounds like Tennessee, Tennessee, Tennessee. Sounds like a, if you say it, how the syllables fall on one another. But these two are not normally a problem to distinguish. Okay, because remember, the patient is not going to lie there with no issues and heart failure. He's going to be tired, maybe his legs are swelling. There's going to be a whole syndrome that the patient has. So you would suspect it, hopefully from your history and from your peripheral examination, that this patient has probably got a heart problem. Okay, it's unlikely just to find one that is gallops, a gallop and S3 and think, heart failure. No, it's normally a patient will have symptoms about these things that guide you to go look for it. Okay. Are we all happy about these things? Okay, now, let's just quickly, before we go on to clinical examination bits, talk about murmurs. So, to make it really easy, there's only two phases of the cardiac cycle I can discuss. It's either systolic or diastolic. Okay, I'm spelling it terribly here. You realize it. Is that it better? Yes. Okay. So in diastolic, there's no pump behind it. Systolic has got the pump going. So any murmur that in systole can potentially become quite loud. You can imagine with that pump behind it and the force that it can generate. Diastolic murmurs are normally softer because it's passive flow. There's not a pump system that's driving that murmur. Okay. So the way we grade these murmurs are a bit different. So 1, 2, 3, 4, 5, 6. 1, 2, 3, 4. So normally we talk about Levine's classification to grade the loudness or the intensity of a systolic murmur. There's a distinguishment that's made between 3 and 4, and that's quite a nice, useful one. A 4 out of 6 murmur has got a thrill to it, whereas a 3 out of 3 is just loud but no thrill. So what is a thrill? Who knows the definition of a thrill? Anybody? Colin?
It's a palpable murmur.
It's a palpable murmur. That's exactly what it is. Is it from my notes?
Yes.
Perfect. So, how can I explain a palpable murmur? Can you see I'm putting down here a big speaker, connecting it to the music player. Now we switch on the volume. Can you hear the music? Okay. The speaker is not moving, it's not vibrating. Now I ask it to please put up the music, the volume. Now the speaker is starting to vibrate. from the distortion of the sound. Okay, so now the speaker is at risk of failure. Okay, but if you put your hand on the speaker, can you feel the vibration? That's a thrill. So that the level of turbulence generated by the murmur is so intense, it vibrates. That's why you feel it. So if you feel over the aortic valve and you feel like that's a thrill. It's different from a palpable heart sound, which is just a tap. This one is a vibration. Okay. So the way to distinguish these are quite easy. If you feel the thrill, you know you're dealing with a 4, 5, or 6 out of 6 intensity murmur. So then you just listen to the intensity, and if you can hear that murmur listening without touching the skin, you can hear it. That's a 6. It's the loudest. Okay, you can actually hear it without a stethoscope hovering your ear over the patient's chest. A 5 is if you stethoscope and you touch half of it, you can hear it. A 4 is you need to put your full stethoscope down to hear it, but you can also feel a thrill. A 3 is loud, no thrill. 2 is easily heard, no thrill. 1 is very quiet room, good stethoscope, oh there it is. Okay. So that's Levine's classification. Now, listen to me. The diastolic classification is exactly the same like the systolic one, but because I explained to you that there's no pump behind these ones, they can't get up to a 5 or a 6. So they only go to a 4. So if you feel a thrill and you hear that the murmur is not on the pulse, it's between the pulse, then it's a diastolic murmur with a thrill. It's a 4 out of 4. There is imaginary a 5 and a 6. But we don't talk about them because the grading only goes to a 4. So a 2 out of 4 and a 2 out of 6 are the same intensity. The one just means it's a systolic one and the other one means it's a diastolic one. So don't even think about the numerator at the bottom. Just listen to, it's the top one that counts. What's on top of the fraction. Okay. Now, how many heart valves are there in the heart? 4. So how many different murmurs can there be from the valves? The aortic valve can be what? 8. Either stenosis or incompetent. Each of the valves can be incompetent or regurg and stenosis. Alright. All you have to know is, if I can find out that this murmur is on the pulse, it's a systolic murmur, you've ruled out 4 of the 8 murmurs. So that's why it's so critical that you be able to locate the murmur, the timing of the murmur in the cardiac cycle, because it halves your differential diagnosis. Isn't that great? Makes it much easier. That's if there's only one valve pathology. Can you imagine if there's 2 valves, then it's like an orchestra there. It becomes really difficult. We wouldn't expect you to figure it out, but it just shows you it can become quite complex. Okay. So is everyone happy about these? Now, let's think about this. This is my heart sketch. Right atrium, right ventricle, pulmonary artery, pulmonary valve, left ventricle, left atrium, mitral valve, there's the aortic valve. Are you all with me on my sketch? There's the blood coming back. If the ventricle contracts and all the blood goes that way, so that's why all the systolic murmurs must be in that direction. Now let's think about it. Blood contracts, these 2 valves don't close properly, so it leaks, causing a jet, causing turbulence. So tricuspid and mitral incompetence will give you systolic murmurs. Are you with me? The blood moves up here. If that one doesn't open properly, you will have a jet. So aortic and pulmonary stenosis causes systolic murmurs or systolic murmurs. Now, exactly the inverse is now true about diastolic murmurs. If all the blood comes this way in diastole, rushing down there and trying to get back there, that's why Mitral and tricuspid stenosis will cause a jet, causing turbulence. And incompetent aortic and incompetent pulmonary valves will cause turbulence and the jet in diastole. So you can see it's just the opposite. So MS, TS are diastolic murmurs, MI, TI are systolic murmurs. How about that? Are you with me? There's one more systolic murmur that I want you to know. It's also a structural heart defect. It's the brother of the ASD. It's the VSD. Okay, there it is. There. If there's a little hole in the heart, that's why when people talk I've got a hole in my heart, that's what they mean. It's not a gunshot wound. It's a VSD or an ASD. Okay. So if there's a little hole in the septum between the left and right ventricle, and the heart contracts, what's going to happen? It's going to spurt which way? Because the pressure there is higher than here. So you're going to have a jet coming this way, causing a lot of turbulence. What will you normally get with a lot of turbulence? Not a heart sound. A loud what? Murmur. And what is a, how do you know you're dealing with a loud murmur? Thrill. So VSD normally gives you a lovely thrill because it's actually a smallish hole with a large jet, not a lot of blood in volume, but a very significant amount of signs and turbulence. So a VSD will also be in your differential of a systolic murmur. So let's quickly talk about the 5 diffs of a systolic murmur. Where are we going to start? Lungi, give me one. No. Systolic murmur. VSD. Correct. We just talked about it. Think about those that we spoke about. Which valve would give you, at the aortic valve, what would give you a systolic murmur? Which valve lesion? Tina? The aortic valve. What's going to happen to it to give you, to make turbulence? In systole. Yeah. If it doesn't. No, but does it close in systole? It closes in diastole. So in systole the blood goes through it. So what's going to make it turbulent? What's going to cause turbulence in the aortic valve? What? Are you understanding that, or are you just copying this lady? It's your brain. Okay, we'll come back to your brain. So what do you say, aortic stenosis? Yes? Can you give me another one? What's next to the aortic valve? Which other valve? Can you guys see? This is the test. This is if you understand this. But what about the pulmonary valve? Which lesion? Guys, let's stop. You're not getting me. Remember I explained to you, if the systole, the blood moves this way, what's going to cause turbulence going this way? If these valves close properly, is that going to be turbulence? If they close, then you hear the burst out sound, but that's it. What's going to cause turbulence here? Tina, what's going to cause turbulence here? Incompetence, exactly. So if it doesn't close properly but it leaks, then it's okay, because it causes a jet, causes turbulence. So that's why tricuspid incompetence and mitral incompetence are systolic murmurs. Because in systole, the blood goes this way, it will leak. It's supposed to stop here. Happy? Happy? Yeah. Now, the blood now normally moves up the aorta and the pulmonary artery. Over here, it finds the valves. The valves should normally in systole open. No problem, they go through, no turbulence. What's going to cause a jet in the aortic and the pulmonary valves? if they don't open properly. So there's a bit of a narrowing, there's a stenosis. So now the blood's going to go through this narrowing. Okay, causing turbulence. Hence, we say the 4 systolic murmurs from the valves are. Now I need the silence again. Tabu, can you help me? I've got VSD as a systolic murmur. Everyone got that one? Now tell me the 4 others. Yes. Yes. Correct. Yeah, give that man a bell. So when people say I've got a systolic murmur, you think those 5 things. That's my differential. Okay. So what's going to be the 4 diffs for diastolic murmur? Mo?
Memory incompetence.
PI?
Aortic incompetence.
AI?
Vital stenosis and tricuspid.
You see, you guys get it. Well done, give that guy a hand. So you see, it's just the inverse. Because there's only 2 phases. It's either systole or diastole. You either cause the problem in diastole or in systole. Okay, are we happy with that? Your head spinning. You're going to flap a bit at the end of this session. A lot of stuff to grasp. Okay. But this is medicine. This is what we trained you for. Okay. Just to summarize. Remember,